Welcome back to the Deep Dive. Today, we are opening up a file that, I'll be honest, usually sits in a dusty corner of the logistical world until it suddenly becomes the most important thing in your life.
Right.
We are talking about non-emergency medical transportation, NEMT. And before you tune out thinking this is just about, logistics or taxi cabs, I want you to picture a specific scenario.
Okay, which scenario is that?
You're a discharge planner at a hospital. You've got a patient. They've been there for 3 weeks. They're fragile, maybe a little confused, and you need to get them home safely. Or, you're a daughter, and your father needs to get to dialysis 3 times a week. He's in a wheelchair. He's tired. He's vulnerable. You call a number you found on Google. A van shows up.
And that's the moment of truth.
Exactly. Who is that driver? What training do they actually have? Is that van really safe, or is it just like a cargo van with a lift bolted into the back?
That is the nightmare scenario. And it's the reality for thousands of people every single day. We tend to view transportation as a commodity.
Yeah. You open an app, a car shows up, you get in.
But when you add the medical to non-emergency medical transportation, the stakes change completely. I mean, we aren't moving boxes. We are moving people who often have complex, sometimes delicate medical needs.
Exactly. And that is why we are here. We have a massive stack of research today. I mean, we've got municipal codes from Portland, state Medicaid manuals from Louisiana, Virginia, Missouri. We've got accreditation standards from NEMT, training guides from places like Bambi Insights and Route Genie.
It's a lot of material.
It is. And the mission today is to figure out what actually separates a professional healthcare transporter from, a lawsuit waiting to happen.
Or worse, a tragedy. Because let's be really clear about who this is for. If you're a facility manager, you are looking at massive liability if you contract with the wrong company.
Right.
If you are a private individual hiring a ride for a parent, you are looking at the physical safety of someone you love.
So we've structured this deep dive around 3 pillars that just kept popping up in all these documents: safety, reliability, and transparency.
The big 3.
We are going to dig into the regulations that you probably don't even know exist, the driver qualifications you should absolutely demand, and, maybe most importantly, the red flags that should make you cancel the ride immediately.
We're going to give you the tools to actually audit these providers yourself. Because in this industry, what you don't know can, quite literally, hurt you.
All right, let's start with the big picture then. Section 1, the regulatory landscape. And I have to say, reading through these state manuals and city codes, it feels a bit like the Wild West.
Yeah.
Is there actually a standard, or is it just a messy patchwork?
It is absolutely a patchwork, and that is the first danger zone for anyone trying to navigate this. You have federal laws, state statutes, and then these hyper-specific local municipal codes. They all just layer on top of each other.
It sounds confusing.
It can be, but there is one concept that stood out in the research that sort of acts as a glue for the whole industry. It's called the standing in the shoes doctrine.
Standing in the shoes.
Ah.
It sounds almost poetic, but I assume it has a harder legal meaning.
It does, a very hard one. Think about the Americans with Disabilities Act, the ADA. It puts very strict requirements on public entities, city buses, subway systems, to be accessible.
Okay.
Now, a private NEMT company, a small business, might look at that and say, well, I'm a private business. I'm not the government. I don't have to follow all those strict public transit rules.
Which sounds like a logical loophole, right?
Right.
Private businesses usually have different rules than the government.
Usually, yes. But the standing in the shoes doctrine says that if a private entity contracts with a public agency like a state Medicaid program or a regional transit authority to provide that service,
they're on the hook.
They are legally standing in the shoes of that public agency. They inherit the responsibility completely. They cannot cut corners on civil rights or accessibility standards just because they're private.
So if they take the government's money,
to move the government's beneficiaries, they have to play by the government's rules regarding ADA compliance. It sets a floor, a baseline of accessibility.
Okay, so that sets a baseline. But then you look at the states, and the variability is just wild. I was looking at the insurance requirements in our source stack. It seems like where you live determines how much protection you actually have.
Oh, it creates a massive disparity. It's one of the biggest issues. Take California, for instance. The sources we looked at indicate that NEMT providers there generally face a requirement for $1 million in liability insurance.
Per occurrence.
Per occurrence. $1 million.
That feels like a robust safety net.
It is. It reflects the litigious nature of the state and the high cost of medical care. But then you just flip the page to Florida. The requirement there for commercial auto insurance is $300,000.
Wow. That is a $700,000 gap in coverage.
It is, and you have to think about what that means in a real-world scenario. If there is a catastrophic accident involving a permanently disabled patient who now needs lifelong care, $300,000 is gone in the first week of ICU.
It's nothing.
And then what? The family is left holding the bag.
And Texas complicates it even further, doesn't it?
Texas is really interesting because it bifurcates the rules. They have distinct requirements depending on whether you are serving Medicaid clients or the private sector.
So it's not a one-size-fits-all license?
Not at all. So if you are a facility manager in Texas, you can't just assume, oh, they're licensed, they're good. You need to ask, license for what? A provider might be compliant for private pay, but totally unqualified for Medicaid, or vice versa. It's a crucial question to ask.
Okay, now, sitting on top of all these local rules are the brokers. We saw names like Motive Care and MTM in the documents. For someone who just wants to book a ride, who are these guys?
Think of them as the gatekeepers for the state. A state Medicaid agency doesn't want to manage contracts with, say, 500 little mom-and-pop van companies.
It would be a logistical nightmare.
Total nightmare. So they hire a massive broker like Motive Care to manage the entire network for a whole region or state.
So the broker acts as the middleman.
Exactly. They handle the dispatch, the billing, and this is the key part for our conversation, the compliance. The sources mention that these brokers conduct field audits. They literally send people out with clipboards to inspect the vans, check the driver's badges, pull on the seatbelts.
Which sounds great if you're on Medicaid. You have this giant corporation checking your driver for you.
It's a layer of protection, for sure.
But what if I'm just hiring a ride for my dad? Using my own money. I don't have Motive Care looking over their shoulder.
And that is the crux of why we are doing this deep dive. If you are a private pay client or a facility manager contracting directly, you are the broker. You are the auditor. Nobody is coming to check that van unless you do it.
That's a really sobering thought. I am the compliance officer.
You are?
So let's talk about what we need to be auditing. Let's move to the person behind the wheel. Section 2. The driver.
Or, as the industry best practices describe them, the caregiver on wheels.
Caregiver on wheels. That's a strong distinction. I think most people think, do you have a license? Can you use Google Maps? Okay, you're hired.
And that mindset leads directly to lawsuits and poor outcomes. A taxi driver's job is navigation. An NEMT driver's job is patient safety. The driving is almost secondary.
That's a good way to put it.
You are often transporting people who are cognitively impaired, physically frail. Maybe they're recovering from anesthesia or they're in pain. The driver is the only other human being in that vehicle with them.
So let's look at the physical requirements first. The sources cite the DOT physical, specifically 49 CFR 391.41. I assume this was just, a vision test.
It's so much more than that. It's a full medical certification, the same one a long-haul truck driver has to pass. Yes, they check vision and hearing, but they also check for a history of seizures, insulin-dependent diabetes that might be uncontrolled, or high blood pressure that could lead to a stroke behind the wheel.
Why is the physical health of the driver so critical? I mean, for the most part, they're just sitting there driving.
Are they, though? Think about the actual mechanics of the job. You arrive at a home, you have a patient in a manual wheelchair who weighs 200 pounds. You have to push them up a ramp into the van.
Right.
You have to bend down, maybe kneel on the floor of the van to secure 4 different tie-down straps, making sure they're tight. You have to reach over to secure a shoulder belt.
So it's actually manual labor.
It is heavy physical exertion. And if a driver isn't physically capable, 2 things happen. 1, they get hurt. Or 2, they cut corners because they can't physically do the job properly, and that's when the patient gets hurt.
Okay, that makes sense. Now let's talk about who these people are. Background checks. I was really impressed by the Portland.gov source, specifically their section 16.40.770. They seem to take this incredibly seriously.
Portland has what I would consider a gold standard approach. It's very comprehensive. They require annual checks via an accredited third party. But what's fascinating is their list of disqualifiers. They don't just say no criminals. They have a concept of barrier crimes.
Barrier crimes. I've heard that term in social work and healthcare, but how does it apply here?
A barrier crime is an offense that fundamentally conflicts with the duty of care you owe to a vulnerable person. So, obviously, violent felonies are on the list. Portland has a lifetime ban for any felony involving physical harm.
Lifetime. That's a high bar. No second chances.
It is. If you assaulted someone 20 years ago, you are not driving a vulnerable patient in Portland today. Period. They also have a 10-year ban on other felonies and a 3-year ban for having your driving privileges revoked.
But it gets more nuanced, right? The sources from Louisiana and Virginia bring up healthcare fraud as a barrier crime.
Yes, and that one caught me off guard at first, too.
Me too.
Yeah.
I get why you don't want a violent person, but if someone committed billing fraud 10 years ago, why does it make them unsafe to drive a van?
It's not about physical safety in that case, it's about system integrity. The driver is the front line against fraud, waste, and abuse. They're the ones filling out the trip logs. They're the one who signs off, "I picked up Mrs. Smith at 2 p.m. and drove 15 miles."
Ah, I see. So if they have a history of fraud, you can't trust that log.
Can you trust it at all? They might be helping the company bill for ghost rides, rides that never happened, or padding the mileage.
Okay, that clicks.
And in a Medicaid system that is already stretched so thin that integrity is absolutely paramount.
And then, of course, the sex offender registry check.
Mandatory. Non-negotiable. End of story. You are dealing with the elderly, the disabled, sometimes children. You cannot have someone on that registry alone in a vehicle with those populations. It is a strict liability issue for any company.
Let's pivot to the drug and alcohol testing. The sources mention pre-employment and random testing. Is this standard across the board?
It should be for any reputable provider. It's a must. They test for the standard panel marijuana, amphetamines, opiates, cocaine, the works.
And this is pre-employment and also random?
Yes, both. But the one policy you really want to ask about is post-accident testing.
What does that entail exactly?
It means if a driver is involved in any incident, even a minor fender bender where nobody is hurt, a quality provider's policy is to pull them off the road immediately and send them for a drug and alcohol screen.
Why is that so important?
It protects the company, for one, but it also reassures the client. If your mom was in a van that had an accident, you want to know for a fact that the person behind the wheel was sober. It removes all doubt.
Okay, so we have a driver who is physically fit, vetted, and sober, but do they actually know how to do the job? This brings us to Section 3, training standards. The sources call these the green flags.
Yes, and there are some acronyms here that our listeners really need to memorize. If you are interviewing a provider, write these down. The big one is PASS.
P-A-S.
Correct. Passenger Assistance Safety and Sensitivity. It is the industry benchmark. It comes from the Community Transportation Association of America, or CTAA.
I want to dig into that sensitivity part of the name. Usually training is technical, how to operate the lift, how to secure a chair. Sensitivity sounds, soft. Why is it a core requirement?
Because the passengers aren't standard cargo. The human element is everything. Let's say you're picking up a nonverbal patient with autism. They might be extremely sensitive to loud noises or unexpected touch.
Sure.
A standard taxi driver might turn up the radio or try to shake their hand or pat them on the back, and in doing so, cause a complete meltdown.
Right, creating a crisis before the car even moves.
Exactly. Past training teaches the driver how to recognize those needs, how to communicate with someone who has dementia, how to respect the personal space of someone in a wheelchair. It also covers things like service animals. You can't just tell a blind passenger to put their guide dog in the trunk. There are laws and protocols.
I noticed the curriculum also includes bloodborne pathogens. That feels very medical for what we think of as a driver.
It's the reality of the job. Drivers aren't EMTs, but they are transporting sick people. People have nosebleeds. Dialysis ports can leak. Catheters can leak.
It's not pleasant to think about, but I guess it happens.
It happens all the time. If there are bodily fluids in the vehicle, the driver needs to know how to clean it up safely without exposing themselves or the next passenger to a potential infection. They need to know what a spill kit is and how to use it.
Another acronym in the mix is CTS Certified Transport Specialist. This comes from NEMT. How is this different from PASS?
Think of PASS as the foundational essential safety course. CTS is like the master's class. It's a tiered accreditation that focuses on professional ethics, risk management, advanced customer service.
So it's a higher level of professionalism.
It is. If a driver has a CTS certification, it signals that they view this as a career. They aren't just driving a van until they find a better job. They've invested in their own professional development.
Now, here's where I want to play devil's advocate for a second. The sources all emphasize first aid and CPR, specifically the American Heart Association Heart Saver standard.
Yes, that's the one.
Is that realistic? These are drivers making maybe $18, $20 an hour. Are we expecting them to be paramedics? Is it fair to put the burden of saving a life on them?
It's a fair question, but you have to look at the patient profile. You are driving someone home who just had major surgery, or someone who just had 4 hours of dialysis and is incredibly weak, and their blood pressure is unstable.
So the risk is higher.
The chances of a medical event happening in an NEMT vehicle are exponentially higher than in an Uber. We aren't asking them to perform a tracheotomy. We are asking them to recognize if someone stops breathing, start compressions, and call 911.
It's about being a bridge to the first responders.
Exactly. It's about stabilization. The sources even mention opioid response training now, recognizing an overdose and maybe even administering Narcan. In many communities, that is a baseline survival skill.
Defensive driving is another one on the list. But the sources describe it differently than what I learned in driver's ed. It mentions G-forces.
This is all about physics. Host, imagine you are sitting in the driver's seat. You have a steering wheel to hold on to. You have a seatbelt that locks. You can anticipate the turn because you're the one controlling it.
Right. I brace myself.
You brace yourself. Now imagine you are sitting 4 feet behind the driver in a wheelchair. You are facing forward, but you have nothing to hold on to except your armrests. You are strapped to the floor. When that driver takes a sharp right turn at 20 miles per hour,
I get thrown sideways.
violently, because you are higher up, your center of gravity is higher in a wheelchair, you feel those lateral G-forces much more intensely. A turn that feels spirited to the driver feels terrifying and can be dangerous to the passenger.
So defensive driving in NEMT isn't just about avoiding accidents.
It's about smoothness. It's about managing momentum so the patient isn't getting tossed around like a rag doll. It's about stopping gradually so the patient's neck doesn't snap forward. It's a completely different skill set.
And checking the weather. The sources mentioned managing high heat and AC.
Thermoregulation. This is critical. Many elderly patients or patients with certain conditions cannot regulate their own body temperature effectively. If it's 90 degrees outside and the driver has the AC on low because they are fine, the patient in the back, who might be dehydrated from dialysis, could go into heat stroke. A trained driver checks the rear climate constantly and communicates with the patient. Are you comfortable? Too warm? Too cold?
Last point on training. IPA. We know doctors and nurses have to follow privacy laws, but drivers.
Absolutely. Drivers are classified as business associates under IPA. Look at what they carry, a manifest.
The clipboard with the schedule.
That clipboard has names, home addresses, and destinations. If the destination is DaVita dialysis, you now know the patient has kidney failure. If the destination is community oncology, you know they have cancer. That is protected health information, PHI.
So the classic coffee shop scenario.
Is a major violation. If a driver leaves that manifest on the dashboard while they run into Starbucks and someone walking by reads it, that is a breach. If the driver is chatting with the barista and says, "Man, I just took this guy to the HIV clinic," that is a federal violation.
It seems small, but the dignity aspect is huge.
It's everything.
Okay, let's move to the hardware. Section 4, the vehicle. If you are a facility manager or a family member, this is where you might want to get out your tape measure. The ADA has some very specific numbers, and I want to know why they matter. Let's start with the door height. 56 inches.
56 inches is the magic number.
Why not 50? Why not 60? What's special about 56?
It's all about the geometry of entering the vehicle. A person in a modern power wheelchair sits quite high. Their head is much higher than someone in a standard car seat.
Right.
If the door opening is too low, the driver has to do something incredibly dangerous. They have to tilt the wheelchair back to duck the patient's head under the door frame.
Oh, that sounds incredibly unstable.
It is. You are tilting a 300-pound chair with a person in it while balancing on a metal lift, maybe in the rain. It's a recipe for a fall. 56 inches ensures the patient can enter in a dignified, upright position without risk of head trauma.
Now, the lift itself. The sources say it must have a design load of at least 600 pounds.
That's the minimum. And honestly, with modern bariatric power chairs, which can weigh 400 pounds on their own, 600 pounds is cutting it close. Many quality providers are moving to 800 or 1,000-pound capacity lifts.
And the sources mention a safety factor.
Yes, a safety factor of 6 for working parts.
What does a safety factor of 6 mean in plain English?
It means the engineering is intentionally overkill. It means that if the lift is rated for 600 pounds, the actual metal, the hydraulics, the chains, they shouldn't technically fail until they're under a load of 3,600 pounds.
Wow.
And you need that. Lifts get used 10, 20 times a day. They vibrate on the road. They rust. They wear out. That over-engineering is the buffer between a safe ride and a catastrophic mechanical collapse.
And the barriers on the left.
The roll stops, absolutely critical. These are the little metal flaps on the front edge and back edge of the lift platform. When the lift goes up, those flaps must lock into the up position automatically.
To keep the chair from rolling off.
Correct. It happens more than you think. A driver forgets to set the brakes on the chair, the lift jerks as it starts, and the chair rolls right off the platform while it's 3 feet in the air. If those barriers aren't working, you do not get on that lift. Period.
Let's talk about ramps. For vehicles that use ramps instead of lifts, the ratio is 1.8.
Ideally 1.12, but 1.8 is the common minimum you'll see. That means for every 1 inch of rise from the ground to the floor of the van, you need 8 inches of ramp length.
So if the floor of the van is 20 inches high,
You need a 160-inch ramp. That's over 13 feet long.
that's a very long ramp. Why can't it be steeper? It seems more efficient.
Physics again.
Mm-hmm.
And human effort. Have you ever tried to push 250 pounds up a steep hill? It's dangerous for the caregiver. They could strain their back or lose their grip.
Okay, good point.
But for the patient coming down the ramp, a steep ramp feels like you're falling. It feels like you are going to tip forward right out of your chair. A shallow, gentle slope is absolutely essential for both safety and the patient's comfort.
Okay, once the inside, we get to the securement systems, the 4-point standard.
This is the golden rule of NEMT. A wheelchair must be secured to the vehicle floor at 4 separate points, 2 in the front, 2 in the back.
I've seen drivers just throw a strap on the back and say, the brakes are on, you're fine.
And that is a major, major violation. The brakes on a wheelchair are not brakes. They are parking locks.
What's the difference?
They are designed to keep the chair from rolling away on a flat surface at the grocery store. They're made of plastic and light aluminum. In a 30-mile-per-hour crash, the forces involved are immense. Those little plastic brakes will snap instantly. The 4-point tie-downs are the seatbelt for the chair. They bolt it to the frame of the vehicle.
And there's a movement rule mentioned in the sources.
Yes. This is a great practical tip for anyone listening. Once the driver has tightened those 4 straps, and you should hear the retractors clicking, that distinct clack, clack, clack sound as they tighten, you should be able to grab the chair and shake it.
And what should happen?
It shouldn't move more than 2 inches in any direction. If it's sliding around, it becomes a multi-hundred-pound projectile in an accident.
And the passenger needs their own seatbelt too, right?
This is a crucial point that's often missed. The belt on the wheelchair, the one that goes across their lap, is usually just a positioning belt. It keeps them from slumping forward. It is not crash-rated.
So it won't hold them in a crash.
Not at all. The driver must pull a separate lap and shoulder belt from the wall of the van and secure it over the patient, just like any other seatbelt. If they skip that step, they are putting the passenger's life at risk.
Let's touch on maintenance. Not just the engine, but the things you can see.
Well, hygiene is a big one. The NEMT standards are clear. Interiors must be free of grease, dirt, and biohazards. But it's also about functionality. Does the AC work properly? Does the heater work? These aren't luxuries. They're medical necessities for some patients.
And visual identification, you mentioned this earlier.
It's all about transparency and professionalism. The vehicle should have the company name and a unique vehicle number clearly visible from 3 angles, front, side, and back.
Why does that matter so much?
Imagine you are an elderly patient, maybe with vision problems, waiting at a crowded hospital curb. 5 identical white vans pull up. Which one is yours? Clear branding helps the patient feel secure. And from a safety standpoint, it prevents ghost operators.
Those operators.
An unmarked van could be an independent contractor using their personal vehicle to skirt commercial insurance rules. You want to see permanent banding, not a magnet they can take off.
This leads perfectly into Section 5, Operational Transparency and Ethics. We touched on fraud earlier, but let's go deeper into FWA fraud, waste, and abuse.
This is the dark underbelly of the industry. Because Medicaid and brokers often pay per trip or per mile, there is a powerful financial incentive for bad actors to cheat the system.
What does that actually look like in practice?
A common one is loaded mileage fraud. This is where a driver drops a patient off but keeps the meter running, so to speak, and bills the state for an extra 20 miles they never drove with the patient.
Wow.
Or trip chaining. This is where they pick up 3 different patients, drive them all over town for hours to rack up miles, and then finally drop them off, often late for their appointments.
That trip chaining sounds absolutely miserable for the patient.
It is. Imagine sitting in the back of a van for 2 hours after a grueling dialysis session because the driver is picking up other people across town. It's physically exhausting and ethically bankrupt.
So how does a client or a facility play a role in preventing this?
Verification. If you're a facility manager, check the trip logs against reality. If a driver claims a trip took 90 minutes but Google Maps says it should take 20, ask questions. If you're a family member, look at the explanation of benefits from the insurance or Medicaid. Did they actually pick up your mom on the days they billed for?
Let's clarify the insurance piece again.
Yeah.
You mentioned general liability versus auto liability earlier. What is the practical difference for a client?
Auto liability covers what happens in a crash on the highway. General liability, or GL, covers the operations outside of a crash. It's the professional liability piece.
Give me an example.
Okay. Let's say the driver is helping your dad transfer from his bed to the wheelchair inside your house. The driver slips, loses their grip, and your dad falls and breaks a hip. The van is parked outside. It never moved.
So the auto insurance won't cover it.
Exactly. Auto insurance will likely deny that claim because it wasn't a car accident. You need the general liability for that caregiving part of the job. That's the slip and fall coverage. A quality provider needs both, with high limits, to ensure there is a deep pocket to cover medical costs if negligence occurs.
And technology plays a role here too. GPS tracking.
It's the standard now. It's non-negotiable. It verifies location and timeliness. It proves the vehicle was at the pickup address at the right time, but it also helps dispatchers monitor for that trip chaining issue we talked about. It ensures that routing efficiency isn't coming at the cost of patients' suffering.
Okay, we have covered the rules, the driver, the vehicle, and the operations. Now let's get really practical. Section 6, warning signs and red flags. We are building a runaway list for our listeners.
Let's do it. And let's start with the most visible one, the dirty van.
If the floor is sticky,
If the interior is filthy, fast food wrappers, stained seats, dust everywhere, it is a massive red flag. Safety culture is holistic. You rarely find a mechanic who meticulously checks the brake pads and the hydraulic fluid, but allows the cabin to be a trash heap.
that's a great point.
If they don't care about what you can see, they definitely don't care about the maintenance you can't see.
Second red flag, lack of branding.
Magnetic signs, we touched on this. If the company logo is a floppy magnet stuck to the door, or if there are no markings at all, be very wary. Professional fleets commit to their brand with vinyl wraps or paint. A magnet suggests, I do this part-time, or I swap the sign between vehicles to hide from inspectors.
Okay, next, core securement habits.
Watch the driver's hands when they work. Do they struggle to operate the lift? Do they look at the tie-down straps like they've never seen them before? If they fumble, they haven't been trained properly.
Or worse.
Or worse, if they try to skip straps. If you ever hear a driver say, oh, we're just going a few blocks, 2 straps is fine.
That's a get out of the car moment.
Immediately, you thank them for their time, you get the patient out, and you call the company to complain. Just a few blocks is where most accidents happen.
Inappropriate communication. What does that look like?
If the driver is rude, rushing the patient, or, and this drives me absolutely crazy, on a personal phone call while working, we talked about hands-free laws, but even on a hands-free device, if a driver is arguing with their spouse or chatting with a buddy while loading a vulnerable patient onto a lift, their attention is divided. That's dangerous.
And missing decals.
Yes, look at the windshield and license plate. In Missouri, our sources point to the LGTC decal.
LGTC?
Livery, gang, taxi, and commercial. It's a specific inspection sticker from the Highway Patrol for vehicles for hire. Other states and cities have similar permits. If the sticker is expired or missing, the vehicle might not be legally on the road.
Finally, the big one, the too cheap trap.
This is the hardest one for people because everyone is on a budget, but you have to do the math. Commercial auto insurance for one of these vans can be $10,000 to $15,000 a year.
Wow.
A new, properly converted wheelchair van costs $80,000 or $90,000. Then you have gas, maintenance, driver training, salaries.
So if someone quotes you a ride for $20?
They are cutting corners somewhere. Guaranteed. They might not have the right insurance. They might be paying the driver under the table. They are almost certainly skipping preventative maintenance. High-quality NEMT is expensive because safety is expensive. If the price seems too good to be true, the safety net probably doesn't exist.
That is a crucial reality check.
Yeah.
So let's bring this all home. We have thrown a ton of information at our listeners today.
We have a lot of detail.
If we boil it all down, what is the single core message?
The core message is that NEMT is a professional healthcare service, not a taxi service. It is heavily regulated for a very good reason, and those regulations exist to protect the passenger.
And for our audience, the facility managers, the discharge planners, the families making that call, what is their job now? What do they do with this information tomorrow?
Their job is to inspect. Don't trust, verify, don't take it on faith. Ask to see the certificate of insurance, look at the tires on the van, watch the driver secure the straps. You have the right to ask these questions, and a good provider will be happy to answer them.
You mentioned a thought during our prep for this that really stuck with me. about how we should view the ride itself.
Yes. The next time you book a ride for a patient or a loved one, I want you to ask yourself this one question. Are you just hiring a ride, or are you hiring a mobile extension of their healthcare?
A mobile extension of healthcare.
I like that. Because that is what it truly is when it's done right. The compliance paperwork, the background checks, the 56-inch door height, it all seems boring and technical on paper. But in reality, it is the blueprint for dignity and survival on the road.
That completely changes the perspective on what can seem like a simple task. Expert, thank you so much for walking us through this deep dive.
My pleasure. Stay safe out there, everyone.
And to our listeners, thank you for trusting us with your time. Remember, ask the hard questions, check the details, and we will see you on the next deep dive.